and allowing me to speak just for a few moments into your life, into your mission, and the context that you're serving. And let me also take a one more second and just say thank you to each and every one of you who are serving uh, this population of community that is unfortunately widely marginalized and overlooked. And I really believe that we're each doing the work of God as we are helping serve those and love those who in our community are dealing with substance use issues. And so I appreciate this opportunity today, and I hope to share some practical information as well as simply giving a little bit of our story. And like I said, or like James shared, uh, at the end, love to answer any questions and connect with anybody just to build more relationship and cheer each other on the front line. So I have a little presentation here, and we will make the PowerPoint available to anybody who would like to get the information afterward. But I'm going to go ahead and share that screen now, and that should be coming up now. So let's go ahead and let me just do one more thing. Okay. So this message today, we kind of titled this Frontline Faith Leaders and Substance Use. Again, my name is Lance Rhodes. I'm the pastor of Tree of Life Open Bible Church, which is in the south part of Pittsburgh, Pennsylvania. And I also am the lead of the South Pittsburgh Opioid Action Coalition, which is a coalition that is not a religious coalition, but is made up of both key stakeholders, people who are providing direct service and care in our near community, as well as concerned citizens and loved members of those who have substance use disorder. And so our objectives for today, we're going to identify stages of substance use in their local community and our response for each. And I'm hoping that you'll be able to take this and apply it to your local region as well. We're going to list some ways that faith communities could be involved in caring for those who are struggling with substance use disorders. We're going to verbalize ways to differentiate those who are struggling with substance use disorders in order to respond appropriately. And lastly, we're going to articulate the importance of how faith communities can effectively impact the community as a whole. And so let me tell you a little bit about my personal story. My wife and I started our church, Tree of Life, in a small part of the inner city, originally in the Oakland community, which is the education district of the city of Pittsburgh. We started in our one-bedroom apartment 17 years ago, and we simply began by reaching out to neighbors in our apartment complex and inviting them over for dinner and a Bible study. Over that period of time, for 13 times, we actually moved the church from different locations, from meeting in our apartment to meeting in hotel rooms, and ultimately, landing in a couple of church facilities. We purchased and renovated a bar, and then our last move, which is where we are currently, we moved into a historic Presbyterian church facility, and this is a facility that was originally built in the early 1900s and was a very large church in the south part of the community. And in its heyday, they would have about 1,000 people coming to church here. And we're still a smaller congregation. We would identify as a Pentecostal congregation. And and we moved into this significantly large facility in order to help shape our community in a better way. So when we reopened here, which was about 5 years ago now, and we began engaging with new attendees that were attending the church in the Brookline community, there was a staggering trend that became immediately apparent to me, which was, as I was just sitting down, having lunch, coffee, or whatever with new members, getting to learn about people's stories, I began to find out that many of the people that were coming were themselves struggling with the heroin addiction, or trying to find some level of recovery in MOUD or in inpatient or outpatient, or had a direct loved one that was in immediate care. We opened at the height of the in our community. We opened at the height of the opioid epidemic here, and I had no other experience personally. Myself, I have no lived experience in recovery. I have no loved ones that had engaged in this. I simply came involved in this because of the number of people in our congregation. And I said, I have to do something. I didn't know what on earth to do. And we really needed to identify solutions so that we could process this. And so this brought me, I want to show you real quickly. Here's just a quick shot of our facility here. You know, it's an old historic building. It's a 22,000 square foot property, and it's one of the largest facilities in our community. And we moved from a 2,000 square foot facility, like I told you before. We had renovated a bar and moved into this. It was a significantly big move for us, just as people of faith. It was a really big move, and so for us to do some more projects. So in my assessment of attempting to identify what we could do in order to help individuals in our community that were struggling, we had a much bigger street presence. Everyone was coming to the church. We didn't know how to respond immediately. And so I started doing some research, and I stumbled upon a study that's not particularly faith-based, but it really intrigued me. And it was a study on mass casualty incidents. You might not know what the mass casualty incident is, but this is how the World Health Organization defines a mass casualty incident. And this is an event that overwhelms local healthcare systems, where the number of casualties vastly exceed the local resources and capabilities in a short period of time. An MCI can rapidly exhaust available resources for not only the MCI, but also normal day-to-day tasks in the hospital. And each hospital should institute a surge plan of preparation for anticipated, progressive, or insidious and sudden onset or no notice events like disasters occurring within our communities. And so this was just something I just stumbled upon. And it was a study that was specifically about what would happen if a hospital had an incident where there was a challenge where they ran out of hospital beds or doctors, or what would happen if part of the building caught on fire or something like that. And it was a study in how hospitals could prepare for mass casualty incidents. And this really got my brain spinning. I thought, well, that's what we were dealing with. We were dealing with mass casualty incidents in our community. Overdose deaths were through the roof. I ended up building partnership with the funeral homes in our community during the peak of the overdose deaths. And I was the on-call pastor to do funerals for anybody in the community that died of an overdose that did not have a local church. And so I became known in the community as the pastor who helped in these kind of incidents. And so this study came out and said there were 4 steps to preparing and dealing with a mass casualty incident. And so these 4 steps are here as follows. The first step is mitigation. And what mitigation is in a perfect world where you spend time ahead of time getting everything ready so that you could try to stop a mass casualty event before it began. Unfortunately, when we opened our church, we were already in the middle of it, so we kind of already missed this step. Step number 2 for phase 2 is the preparedness phase, and that's where you could gather supplies, stockpile resources, the things that you see are weaknesses, and what we could do. And unfortunately, again, like I said, we were already in phase 3. Phase 3 of the mass casualty incident study was the response phase, and that's where the organization, the hospital, was trained how to respond and deal with the immediate onset and the surge capacity. And then phase 4 of this is what's called the recovery phase, and that's how does the hospital get back to normal after there is such an incident. And so when we first did this, and I think now in this post-COVID era that we're kind of entering into, we're going to see what can happen whenever there's strain placed on our public health system. And I think even now there's a lot more of lay awareness of these things. But 5 years ago, when we first started this, I had no idea. And I said, this is what we're going to do. And I said, we're in the response phase. So what can we do in our response phase? What is the faith leader's response? And The study showed that there were two primary areas that needed to be addressed inside of a faith leader's response. The first part was to create what is known as an incident command system. And the incident command system is, in the context of the study, was creating a central location where there is commonality of language and clear power structures so that everybody involved knew exactly who to report to. Because in the case of emergency, it needs to be clear to everybody. Who are we talking to? Who's the one that's calling the shots here? What's going to happen? What do we do? How do we respond? The second part of the response is what's called as the triaging code. And this is what determines surge capacity. And depending upon the scale of the disaster or the incident, will completely change how the triaging system happens. And as we think about triaging and what happens in triaging in the medical community, this is something that, for example, if there was an incident where there was a fire, and you can say, well, these people have different degrees in burns, and we can triage people by how bad their burns are, and then determine the people that we have the capacity to be able to help, and the people that we don't. And then I realized that in this whole part, there was a justice issue, and this was really my heart. That I think that in all of our hearts as faith, people of faith, that there's something inside of us that when we see injustice, that we there's like an impetus of God that comes into all of us and says we have to respond. And so this justice issue became very apparent to me. And I said, well, this has got to be part of my response. I believe that God has called us as a church to help release the justice of God on the earth. And so as I'm sitting in my congregation, I'm weeping with parents whose children have overdosed and died, and I'm helping somebody who's had another recurrence, and what do they have to do, and how do they go back into life, or people who are losing their children. I mean, there's the list of issues that surround members of all of our congregations who are dealing with substance use issues are astoundingly long. And so these were the things that I wanted to do. And these are things I'm going to encourage you to do today. These 3 steps: build an incident command system, build a triaging code, and identify justice issues. And I think that is our faith leaders' response. So we're going to break this down here for just a few minutes. And the first one here is the incident command system. And I'll tell you a little bit about our story. So we wanted to build an understanding of what was it that, how do we actually communicate? And this is actually how we got involved in leading and being part of the coalition. I wanted to identify who was helping people, how do people talk? And again, I told you, I didn't have any personal lived experience in recovery, so I didn't really know who to talk to. I just said, well, you call the hospital. I didn't at that time really understand, and I definitely had no understanding of different medications for opioid use disorder. I did not know the difference between, Suboxone or Vivitrol. I didn't understand all these things. And so I learned I got to build language because everybody was looking to me as the senior pastor. Pastor Lance, what do we do? How do we help these people? When do we stop? How do we engage? And so I worked to build our coalition and our community, identified who was providing care, who was doing inpatient care, who was doing outpatient care, where is the closest places that people can get medication for opioid use disorders, who do we call when somebody has an incident, how do we get away, deal with somebody who's experiencing an overdose, who is responding and overdosing. And I wanted our church to become the greatest partner and collaborator when it came to this engagement. And so we identified a couple of really important things. Now, I live in a major city, and so we have a very strong health department. And so I knew that we needed to identify who in the health department was involved in the overdose issues, and found out that there really wasn't very many people. And then we had to become a voice to say there needs to be more support here. We identified who were people that were giving away Narcan, and how could we give away Narcan, and how could we get Narcan in order to give it away. And our creation of this incident command system and identifying specifically who locally can we refer people to, who were the safe places whenever we identified somebody. I learned about syringe programming. I never heard of syringe programming prior to this, but I said, okay, now I know who is doing it where and how do we get people involved. And if somebody comes to me and says, look, I'm a mess, I need this, I can say, let's get you here, or let's get you to this person, or, you know, we identified phone numbers, we created phone lists when somebody calls. And the key is here, especially for faith leaders. I mean, as a senior pastor, my responsibility is much bigger than this. I also have to engage everything else that's going on in my congregation. So I had to develop systems so that other people in my congregation could know who to talk to and how to get a hold of information. So we built internal communication systems as well, so that there was regular and consistent information. And we built an incredibly strong command center in order to make this work. And our command center was built, we started this on what I learned was a study, and this is my point three, a study that was done. And I know probably many of you have heard this study before, but there was a study, and one of the people here locally became one of the strongest advocates for identifying person first language, or shifting language inside communities away from using harsher words when we're talking about people who have a substance use issue. And so, because I didn't know that, I was just said, well, somebody's addicted, and I didn't realize that that language in and of itself was so bleak and so dark. And that was the very first step for me. And so I made a commitment, not only in my church and among all of our staff and all of our volunteers. We do regular training about person first language, and we've developed the term destiny language. And we use the term destiny language because as a person of faith, I believe that God has placed inside people destiny, and that destiny is something that is greater than the disease that they might identify with. So when people say, I'm an addict, I would say, you're not an addict. I don't like that word. I don't want to identify people as an addict. I want to identify them as a person first. So I would just tell them, look, you're a human being that has a substance use disorder. And so and we try to really shift language. And this is, I think, one of the strongest areas. And in a congregation, we're an inner city church. And in an inner city church, we have every political spectrum that exists in our congregation. So I'll have somebody in our congregation that stands up and says really hate-filled words about people in addiction, and they use really dark language. And I said, we got to change those words. And then we also have people that might speak very compassionately, but I had to find a way to get to it. And I found that faith and person first language is one of the things that we could all agree on. Or does it matter what side of the political spectrum you are? We want to see every neighbor as a person that God created, as a child of God, as someone who has a destiny, and a destiny that's not found within any kind of disease or sickness that they have. We don't talk about people who have cancer as just being, cancer. We don't talk people who have diabetes as just being a diabetic, but they're a human being. And we work with these individuals, and I wanted to use the same thing. And so person first language was one of the biggest parts of our life, and what we did in order for us to build a strong incident command system. And so these three steps here were the very first three steps that we engaged very radically and across our congregation. And ultimately, we held lots of people accountable. As our congregation and our influence began to grow, we actually engaged the mayor when it came to person first language, and the mayor of Pittsburgh committed to shifting policy and procedure in the city and city council, all because of our engagement here, and to encourage others to use person first language. And so this was, I believe, a big win, and something that was driven by our faith, but was just very practical, and we could prove with evidence-based practices as well, with lots of studies on this, and I could refer to many of those at a later point if you'd like. So these are our steps to build our incident command system. Our second phase is triaging. And triaging is hard, but it's something that we have to do. And so ultimately, we triage as a congregation with two phases. First, we have to triage people in our congregation and in our community that have substance use issues themselves. And so that is something that we'll have to deal with. And then we also have to triage the loved ones. And so triaging is basically saying, I want to assess what level of care is necessary. And, as a person of faith and as a faith leader, our primary responsibility is to help impart faith concepts into people's lives. And we understand that that's our primary goal. But I also realize that for people who could experience an overdose related death, our responsibility can be to just help them stay alive. Because if they're able to stay alive, then we can share a message of faith with them and help them identify it within the faith message itself. And we can't do that to them after they've died. And so triaging is a system, and hospitals use this, especially in mass casualty incidents. And the typical system that was promoted by the study was to use a 4-color system, which a 4-color system is red, yellow, green, and black. And so I'm going to break this down a little bit so this makes sense to you. And so each of these systems, each color represents a level of severity that a person might have. And so red represents, these are immediate or tier 1 priorities. These are patients whose lives are in immediate danger, and they require immediate treatment. And these are people that we identify that we can help, or how can we help them? And so as a faith community, we identify, when we look at people who are in red stage, we want to find, what can we do? And honestly, as a faith community, there's only so much that we can do for people who are in red status, because they require a level of care that is greater than a level that we might be able to, or we might be resourced to be able to do. But so I want to say, what do we do with those people? And not only do I, as the pastor, have to know what do we do with these people, but our system has to be simple enough and clear enough so that every volunteer and member of our congregation can step in and help in any given situation. That goes back to Incident Command Center. If we don't have that, then we can't do it. And so we identified, okay, what can we do for people that are in a red state? And those red states, we learned that there was 2 main ways that we could help those people. The first one was naloxone or Narcan. And I'm sure you know what naloxone is, but I became the biggest naloxone advocate in the world. I've got kits everywhere. I've got one right here on my desk. We have them by every door in our room and every first aid kit in our church. We have signs on outside of our building that say, there is Narcan available here, free of charge, no questions asked. Anyone can walk into our church anytime and say, can I please have a box of Narcan? And we'll give it away. And we regularly communicate that to everyone in our community. We write that on, it's on signs outside, it's on social media. We regularly talk about it whenever we do projects. We train all of our staff and volunteers how to apply Narcan, because if somebody's experiencing overdose, they're in a red moment. And there is nothing we can do. There's no amount of preaching in the world when somebody is overdosing right in front of you. There is nothing that you can do other than simply use naloxone. And we trained everyone. That's what we got to do. And so step 1 was get Narcan. And we became big advocates of this. We host regular events in our community where we are distributing Narcan, getting it available, getting it out far and wide, having conversations about Narcan, teaching people how to use it. This was a big first step. And it's easy because, even for the strongest opponents of medication in our faith communities, Narcan is very easy to defend whenever you understand how it works. The second part of the red triage is understanding that there are medications for opioid use disorder as well. And while this might be a little bit more sticky for some people in faith communities, I stand very strong out and tell people that we are not against medications for opioid use disorder. Explicitly, I say this: I'm a pastor. Leave the pastoring to the pastor. Let the doctors prescribe medicine. And so a person who's experiencing an opioid use disorder, who has a relationship with a doctor, and their doctor says that they need to provide medication, I am not going to step in between that as a pastor. That's not my place. My place as a pastor is to encourage people to take their medical issues to their doctor. I will pray for them. When somebody comes up to me and says, I have cancer, will you pray for me to be healed? I will pray with faith for them to be healed. But I will also say, now go to your doctor. Go to the doctor and continue to work with your doctor. And so I'm not going to step in between a cancer patient and their chemotherapy. I'm not going to stand between a diabetic and their insulin. I'm not going to stand between a person who has a substance use disorder and a doctor who says they should be on methadone or Suboxone or Vivitrol or any other medication from there. I'm going to allow the doctors to be the doctors, and I will be the pastor. And so when it comes to red triaging, I don't get involved in this. I don't tell people you shouldn't be on that or you should be on this. I allow the doctors to be the doctors. And so this was a way that I could help myself so that I could serve people. Because when it comes to red people or these tier one immediate needs, we have some responsibility, but ultimately I can't help them beyond that. I can't prescribe medicine. I could give out Narcan because there is a public health order on it, and that's it in our state, and I believe it's in every state. So that's our first tier, red. Now the second one's yellow, and these are delayed or tier two. These are patients whose lives are not in immediate danger and who will require urgent but not immediate medical care. And yellow triage is honestly where I think faith community has the biggest gain, because lay people can help with yellow. All any of us can do in red is just advocate, but we can empower all of our lay people to work in yellow. And so we identify somebody who, maybe they've got their medications kind of resolved and they're in a little bit of recovery and they have some sobriety time under them, and they're not as much of like imbalanced or being afraid of immediately falling back any given moment. So there's not a high maintenance. These are areas that we can empower our congregations to provide peer supports or long-term support. This is where we can get involved and host meetings, whether that's a 12-step or a life recovery or some other form of one internally. Everybody uses their own. People say, which one should we use? I use them all. Use as many, whatever works. If you're the faith leader, you know what works in your community. Use the one that works best in your context. But this is what we deal with people that we identify as yellow. They're not going to die, right today. There's riskier days than other days, but generally these people are not in immediate danger. And so when we have yellow members in our congregation, in our community, we work toward helping them by giving them some support here, giving them some peer support. As we kind of move on, there's green, and these are people that need minimal support, minor injuries, who may eventually require treatment. These are our long-term, long-haul people, and we still need to be aware there's issues here, because a person who has an opioid use disorder, I mean, I remember, member of our church, who comes from meetings, and they had 20-something years, and then COVID, and they thought they would never have a recurrence, and they did, and their whole life started falling apart again. They were green, and then they moved up, right? So we understand that, and we know we cannot ignore our greens. We have to provide help for them, and so we're aware for them. We're providing prayer. But our green triage family, these are people that are great volunteers and great support, and they can help be a peer and a mentor, a big brother, big sister to a lot of people. And so we do identify red, yellow, green. We know they're important, and are all important parts of our recovery program. And so I started going through this and say, who is this? They're green, they're yellow. How do we respond to this person? How do we help them? And being really clear. And then this brings me to my fourth one, which is the hardest one for us to deal with. That's the black tag. Black tag is called the expected. These are the people that have no priority in a mass casualty incident. These are patients that are identified as either dead or have extensive injuries that are so great they cannot be saved with the limited resources that are available. And as a person of faith, this is the hardest one for us, because we want to help everybody, but we are experiencing a worldwide crisis. And it is a manufactured crisis. It is a big issue in our communities, and we all have limited resources. And if we aren't ready to deal with this in our own hearts and in our faith communities, we need to be able to say somebody's a black tag. We have to understand there are limits, and there's a person that far exceeds our ability within our own faith community to be able to help somebody. Compassion fatigue is a real problem in this area. And you yourself as a faith leader, you might be able to have all the faith in the world, but I'm telling you, the people in your congregation, when you start rolling out this program, and then somebody has an overdose and they die, it hurts. It hurts everybody more than you probably realize. And we have to realize that because there are black tags in our congregations, that we are going to need to do as much as we can to protect the emotional health of those that are in our faith communities and those that are leaving. We got to deal with compassion fatigue. We've got to have referral systems handy. We've got to be able to hand off to communities. I mean, I had somebody last night, this real story. A woman came to our church last night. I'm right now I'm involved. We have two Bible studies going on a Saturday night, on a Tuesday night, and I'm leading one. My assistant pastor's leading the other. Somebody knocks on the door, and they share with me that they've been sober for 3 weeks. They're really having a hard time. They just want someone to pray for them. And I, I prayed with them. I gave them the few minutes I could. I do not have any more capacity. There's somebody I don't know. It's a random stranger walking up the street. And I realized in that moment, I have got a Bible study downstairs full of other people that are in recovery that I'm working with. I have an emergency right in front of me. And I have made a choice. And in that moment, I said, I'm going to give you as much time as I can, which was 5 minutes. And then I said, would you like me to call one of the emergency providers for you? And they said no. And I said, well, here's the phone number. Would you like a box of naloxone? They said, I have one. I said, let me give you another one anyway. I said, we'll be here tomorrow. We have more staff available tomorrow if you want more time. But this is all I can do right now. And they cried. We cried together. I gave them a big hug. I prayed for them. And I had to be okay with that, because the reality is demand for resources always exceeds supply. And there's nothing, there's just sometimes that we just can't. And if we get tied up and if we align our own identity as faith leaders and our ability to help everyone, we will end up helping no one. And so this kind of brings me to this question that I was approached with. And so this was a metaphor. There was a helicopter that went out on a missions trip into Africa. And it was a medical missions trip. And there was a team of 4 people. And they brought a limited number of supplies on a helicopter. And the helicopter landed, and they were dealing with a mass casualty incident. And the doctor gets out of the plane, and a man walks up to him and says, please help me, please help me. My friend is bleeding. He's going to die. And so the doctor grabs the resources, and they run out, and they go and they help this person laying on the ground. He's bleeding everywhere. And they spend all this time, the whole team, and they put all this love into this one person. And they save this one person's life. And they get up and say, it's time to go on to the next person. And they do, and they look at their stockpile of supplies, and they spent half their supplies on one person. And there's a second story of the same team, with the same kind of team, with the same resources, who landed in a different part. And they went out and they were approached by somebody who said, please help my friend, he's dying. And they said, I'm really sorry, we can't help them right now. And they went and they set up a command center, and they set up a triaging hospital. And they were able to help about 100 patients with the resources that they had from their helicopter. The question is, which doctor loved more? And the reality is, that is the hardest question. But that is a question that we as faith leaders ask ourselves every day. Did I love enough? Did I love enough? And we're compelled with the love of God. And there are times, and I'll say this, the efficiency of heaven compels us sometimes to pour out all of our resources on one person, because that's the radical love that God has given us. And sometimes the radical love also calls us to tell that one person, I'm sorry, there's nothing I can do for you. Let me help you transition so that I can go help 100 others. And we wrestle with that. There is no right answer. And today, as a frontline faith person, I've had to do both. There have been times where I've poured hours and hours into one person who didn't get much better, but we kept them alive a little longer. And there are times that I've said to those people, there's not much I can do to help. And we're wrestling with that deep ethical issue. And so how do I deal with that? I have peace now. There was a time I didn't have peace. There was a time where my family was suffering because I was putting in so many hours trying to help people who were dealing with substance use issues. And here we are now, having been in this community for 5 years, and unfortunately, overdose deaths are even more increasing because of the pandemic, and we're dealing with issues. And I had to create boundaries. And I want to encourage you as a faith leader to create healthy boundaries. And you do that by building a triage system. And that means sometimes you're going to say, this is as far as I can go, and that's it. And I'm okay with that, because that's what's going to help me to be able to come back tomorrow and continue to serve as I do. And so you define how far your love takes you, and you encourage your congregation, your leaders, your volunteers, your members, in order to serve alongside that path. And if you do that, you'll be able to keep the long haul here, because you'll build systems, and then you'll be guided by systems instead of being guided by somebody, by a particular story or situation. And you'll have to decide that. And so this is why the triaging process is essential to being on the front line. And so I told you there are 3 steps. We have our incident command system. So we build language and systems and structures. Who says what we're doing? How are we doing it? And who do we refer to? And we build triaging systems so we can use that system and point people away where there are systems and where there's help, where people can stay with people long term. And then our 3rd phase, which is our justice phase. And in this phase, I personally believe this is now our next biggest area for faith engagement. And this is really an area that I'm spending a lot of time working in right now in our own mission and ministry that we're doing. This is, how do we engage police? We really began to work with our local police system and EMS systems so that they could leave behind naloxone where there was an overdose call. And so I developed relationships with our local police, our police chief commanders, and our basic system. And every time I'm with them, I thank them for leaving naloxone. I thank them for caring for people who have opioid use disorders in our community. I regularly, I email our commander. If there's an overdose death and the police were there, I email the commander and I say, please thank the officers that were responding for me, and please let them know if they need to talk to anybody, I'm here for them. This area of justice, because if we have the police and we can work with them, and the police, I'm going to tell you this, in light of issues going on in the world right now, the police are looking for support and allies. And as faith leaders, we could be that. Now, I realize there's challenge, and there are just some people that don't want to work with police. And there are some areas where there's a lot of really darkness in the police area. My faith compels me that light belongs in the darkest areas. And so if this is a dark area in your community, I want to encourage you to just step in anyway. And maybe it's in the judicial system. I began getting very involved in this area. And we have elected judges in our community. And so we became a strong weigh-in on helping explain what was going on with judges, asking judges, what will you deal with somebody who comes to you with a crime and their crime is associated with their substance use? How will you respond? And I started holding judges accountable in this area. I also want to encourage us as faith leaders to work in workforce engagement, because there are people who have felonies on their record and they can't get jobs and their life is falling apart and they're engaged in our benevolent resources. But let's find out and create programs or learn how we can onboard people to programs that are active in our community so they can get back into the workforce, so they can get things taken from their record or expunged from their record. Can we involve ourselves? Allow, I just simply believe that justice rolls down from heaven. And as a faith leader, our responsibility is to release justice on the earth. And so if these are areas that we can engage in, let's engage in that. And let's model that even in our own self. If there's an area, can we create policies in our own faith community that allow us to engage volunteers or even staff that have records? And how are we going to respond to that? How can we deal with justice issues? And what will we do whenever we have this issue? We began employing people in our congregation for projects They weren't involved with children, but these were people that had issues of in the Justice Department on their records, and we had to draft policies in order to help them. So we weren't punishing them because of their past, but we were recognizing they were still a green tag, and that a recurrence of use was something that could really happen. And so we began to advocate for policy, and part of our coalition. And one of my projects I'm working on right now, specifically, we're trying to help businesses develop better policies when employing people who have substance use disorders, and we create boilerplate templates for businesses to be able to use. It's one of the projects we're working on right now. We also began to work with our prison system, because we found out our local prison system, if somebody is in prison and they have a substance use disorder, the local doctors were not giving them their medications for opioid use disorder. And we became a strong advocate to say, if somebody came into prison and they had medication before, it's a crime. It's a justice issue for them to not have access to their medication while they're in prison. And I just firmly believe that, and we became a strong advocate. And we're starting to see changes in this. And I encourage faith communities to come alongside of us. And we faith leaders from cross denominations, and not Christian and non-Christian, standing together and saying, this is a justice issue, and we want to work with this issue in order to make this happen. This brings me to my final point. We want to be a faith community that would be missed if we closed. And I have this picture, this black and white picture. And I told you, we took over this old, beautiful, historic Presbyterian facility. And there's a particular picture where, and it's partially cropped here, but it shows there's hundreds of ladies that used to be involved in the women's ministry at the Presbyterian church that we currently occupy. And it's a black and white photo from, this picture was taken in 1938, whenever they were they weren't even at their peak at that point. But I remember coming into this building 5 years ago, where the roof had caved in and the sanctuary was literally unusable. And the church closed as a Presbyterian church, and I don't think anyone in our community noticed. And we bought the building completely under the radar, and nobody even knew it traded hands. But now I can tell you that because of the programming that we do when it comes to recovery, emergency food, our on-site food programming, our child programming, if we closed today, there would be a chasm that would be so great, the entire community would say, no, don't close. We can't have the church close. I want us to lead faith communities that would be missed. And I believe that in this era where opioid use disorders are so broad and so widely reaching, that if we embrace this area and work with this area and become advocates and friends of those who are struggling with substance use issues, they would come and say, like literally, a man came up to me and said, my family would not have eaten had it not been for your church. And I'm thankful for those moments. And here he serves now as a volunteer in our community, because 4 years ago, whenever we were rolling out all these programming, our food pantry fed their family and asked no questions, even though we knew there was issues there. We just gave them food anyway and kept that program going. And now he says his family would have starved if it wasn't for us. We would be missed if we closed. And I want your faith communities, your churches, wherever it is that you're involved, if you suddenly closed, would people notice? And I think if we're engaging this community, a lot of people would notice. So again, I always want to thank you for allowing me to speak here for a few minutes in your lives this morning, in your congregations and your leadership. And I appreciate this opportunity. And I really want to thank James Campbell for allowing me to be able to speak and share this story today. I hope it's been a blessing and encouragement to you. But I wanted to open up the opportunity. If anybody had any questions, I'd be more than happy to answer any questions, a little bit of our church or our personal story, or expound on any of those things that we've been involved with within this as well. We will make the slides available for anybody that wants those. I'm happy to send those out, and I'm happy to connect with anybody that has any questions.
Can I have a question?
Yes, please, go ahead.
Hey, Pastor Lance, thank you so much for sharing your story. And also thank you so much for being so persistent, moving so many times. It's not easy. Moving a ministry so many times from one location to the other, there's discouragement sometimes can happen. So thank you for staying consistent. And finally, God already had a place for you where you now growing. So congratulations on that. I want to ask you something related to when a community of faith or a congregation now moves more into social services. Do you have a separate 501c3 for those social services, or you working on the same umbrella of the 501, of the ministry?
That's an excellent question. And I will tell you this, what we are currently doing, we are doing it under one 501c3. We shifted our bylaws to do so. However, we are ultimately going to be rolling out multiple 501c3s in the long term. So the good news is you can do this, at least in the short term, under one, but there's definitely an increased risk. And working with our insurance company has been the biggest guiding reason as to why we're ultimately going to be rolling some projects out separately, just because the insurance wants the liabilities run a little bit differently. But that's something that is very local to us. So I would definitely encourage you to reach out. Your insurance company is a great advocate for your success in this area. And I would encourage you to connect with them and follow what it is that you want to do. We also, speaking of insurance, to add on that, one of our challenges with our insurance company originally came from doing naloxone distributions. And so we had to get some information clarified with them on the public health order. And ultimately, when we distribute naloxone here, it's being done as a partner of the Allegheny County Health Department, because they didn't want the church distributing it, because the church is not a pharmacy. And so there is some challenges there. And you have, that's like a local thing here. Might be a little bit different in your area, but I would really encourage you, because those conversations I had, it's worth having those conversations. And ultimately, we're ultimately going to be separating things.
And so the hiring process is something that I would like to see if anyone else can contribute to this. When the hiring process, and we all know about the inclusiveness, equality, and diversity, that we all need to understand that how you have worked that out. Being a faith-based organization, and the church, actually, and the name said itself is, Bible first, Bible open. So how you work that out, the hiring process?
Yeah, there's a lot of distinctives that are there. And so part of it is identifying in your bylaws. There are a lot of great resources that are available through different Christian legal firms that can help explain how a church needs to correctly navigate things like equal opportunity law when it comes to hiring with church's clergy, and then bringing on other staff when they're involved in particular other areas. And so, a lot of it's just policy and bylaw stuff that you just have to really work through. But there's a number of great resources that that you could find out online that will help a church navigate through what does that look like and how you want to do that. And if you do something where you're receiving grant funding, you have to abide by those policies too. We have received public grant money for some of the projects that we've done, and that has required us to embrace broader equal opportunity hiring practices. And so we did need to shift some of our bylaws in order to protect our religious initiatives when it comes to clergy and those kind of positions, in order to make that work. But it is manageable. It is a little bit of labor, but it's manageable. Thank you for allowing me to share today. God bless you all, and we'll see you again soon.
Thank you.